the messaging is very simple. It's a straight line. Diversity is incompetence, equity is advantaging people of color at the expense of white people, and inclusion is political correctness, right? They've been able to make that connection very clearly. It is on us to be very clear and precise about what we mean and not be fighting the words the way they define them or be on our back foot. No, it's not incompetence, but to say this is what we mean.
We were trying to figure out what to do to mark 5 years after COVID. I'm sure you've been inundated with coverage and sort of commemoration in different spaces. And Helen, kind of in her signature way, you know, there's not a time that I've asked Helen for something, whether it's extra masks or tests, or can we have 10 slots for vaccines for people who can't get off of their shift and have to come at this. I mean, literally, this has been the role that this hospital has played historically for not just Epicenter, but really for our community. And so it really feels very fitting that we're gathering here. I think for many of you who walked through those halls, for some of you, it was a homecoming because you similarly worked with this hospital and community. We have one person who was born here, who's a New York City firefighter, so I just want to give it up for him for not on that over here. And so, also Jackson Heights native. But you know, so the history is not just 5 years, and I'm not going to tell you all how old Farhan is, but and then we have Joe Betancourt from Commonwealth Fund, which is not just a supporter of Epicenter from a funding perspective, but also just such an important thought partner as we are contemplating the space of health equity. How do we layer information needs on top of people's health needs, knowing that those two things are often not the only needs that the individuals in our communities have. So we'll get to their backgrounds, but I just wanted to begin with you, Helen. Can you situate us where you were 5 years ago?
Is this on? So 5 years at Elmhurst Hospital. Sadly, I think today was the beginning of the lockdown for the community. Sadly, we were inundated here at Elmhurst Hospital with a lot of patients, and I think that's not only where we saw the lines, it was lines of ambulances coming through our emergency room. We saw, you know, here in the hospital, there's certain codes of where how many patients we can take when we're before like a surge, and these were numbers that nobody had seen. I mean, we had like emergency preparedness simulations, and it felt kind of like that from what I hear from my providers. Wave one was a shock to the system, was a shock to the hospital. And, you know, there was a sense of a crisis. It was like chaos, but also very calmness. Dr. Abacoli, who is our emergency preparedness chief for the system, said it was a moment of like complete chaos. But in that chaos, there was also a sense of duty that we had to make sure that we made this sense, right? Because we couldn't figure out what the virus, how it was working, what it was doing, because it would show signs in one patient one way and then show signs in another patient another way. So clinically, there was so much information, but yet no answers. But we still had to take care of the people walking through our doors and protect our patients, protect our employees. And then on top of all of that, we had to figure out information, what was coming out of the hospital, what was staying in the hospital, what was out in the community. It was very, in that sense of like every day was something new, but every day was something learning that got us closer to providing better treatments for our patients. So a lot of people, there's a famous New York Times picture that they took of Elmhurst in wave one. And they said, you know, Elmhurst Hospital, epicenter of the epicenter, not ready. Newsflash, nobody was ready before the pandemic. Nobody. We were just harder hit because of so many social determinants of health. And that New York Times picture, you know, showed the lines, you know, humongous lines of Elmhurst, of people in the community trying to get into Elmhurst. And what that picture doesn't show, they talk about community. We are only, how many of you took the train to get here? Right? It's like 3 blocks to Elmhurst. What that New York Times article did not say is that all those people, those hundreds of people that were waiting to get into Elmhurst, they could have hopped onto the train. There's a lot of hospitals in the city. They could have gone to any other hospital, but they stayed at Elmhurst. They stayed. You know why they stayed? because they knew no matter what, we were going to take care of them. Whether in the scariest moments of their lives, we were either going to hold their hand and tell them it's going to be okay and they can go peacefully, or we were going to hold their hand and say, hey, we can fight this. No matter what, we were going to hold their hands no matter what. And that's why they were on that lives.
Thank you. Joe, where were you 5 years ago?
That's a very
Great. Well, thank you. It's great to be here. Thank you for the kind invitation. Thank you for welcoming us. And so I'm going to give everybody a little bit of background about myself because that'll make sense, I think. It'll help people make sense of kind of where I was 5 years ago. So just by way of background, I'm originally from Puerto Rico, grew up in New York City. I'm from Manhattan. I'm a primary care doctor. And now President Commonwealth still see patients as a primary care doctor. But 5 years ago, I had just been named Vice President and Chief Equity and Inclusion Officer of Mass General. So that's 6 months prior to March of 2020. So in the back end of 19, I've had a career dedicated to health equity before it was knowledgeable or fashionable. Coming out of my personal experience and just desire to make a difference. And so this was a really special moment. I had kind of run this place called the Disparity Solution Center, did a lot of work with organizations across the country. And now I had turned inward to kind of join our C-suite and really build out a plan.
Dark side.
That's right. I came to the wonderful side. So came over to really focus on how we can continue to strive ourselves as an institution around health equity. And I'll just say that a couple of weeks prior, I, like many doctors, were tracking what was kind of happening and the things that you were starting to hear. And I remember seeing a lot on social media what was happening in Italy as an example. You know, Italy was kind of, their surge happened a little bit before us, and the videos and the dispatches that you were hearing from a fairly advanced healthcare system were really alarming. And then if you all remember, one of the first places where COVID really started to pick up, here I am in Boston at Mass General Hospital, was at a conference that they had in Boston, where and those first patients came to our hospital. And so I'll say that I was tracking this. We in leadership started to we said, well, we're going to need to start to shut some things down. So it was coming. And then all of a sudden, the declarations get made. And I remember sitting in my office and thinking a couple of things. Number one, history's told us that natural or man-made disasters or pandemics always disproportionately impact vulnerable populations. Second, I began to say, well, we don't know a lot about this, but we do know it's airborne. And if it's airborne, what are the factors that are going to lead to spread? Multi-generational housing, essential workers who are taking public transportation. So I started to say, this is a perfect storm. And but really, it was like you're waiting. The storm's coming, but you're waiting for the storm to hit, and you're not really sure what to do. We're doing the standard stuff of prepping. And so actually one of the first things I did in our office, so here I'm in an administrative role, and I assembled a team, and I said, we're going to go down to talk to our food service workers, environmental services, and materials management, because these are folks who fit those categories of individuals who are essential workers who live in places like Chelsea, probably the equivalent of an Elmhurst kind of
Hey,
catchment
your
area.
Chelsea is different from ours.
Yeah, very Chelsea. Very different Chelsea. But the bottom line is I had one tool. The one tool I had was being able to go down and speak to people in Spanish and tell them what was coming and how they should prepare and how they should protect themselves. And I think from the very start, the sense was do something every minute. Like, do not sit still for a second because every minute matters. And so that was the beginning. It was the fear. It was knowing what's coming. And it's also knowing who's going to be hardest hit, which is the work that I do in health equity. And just trying to say in that moment, okay, let's just, everybody needs to do something. And that was the something we chose to do in those early days, 5 years.
I just want to stay with you, Joe, to the Commonwealth Fund transition. So what prompted that? And if we could reflect a little bit on 5 years ago and how that impacts your leadership of this fund right now.
Yeah, so I'd been in Mass General for 20 some odd years, and actually about a year after the VP position I mentioned, I was asked to lead our entire system, Mass General Brigham's equity and community health approach to COVID. So really focusing on, all the things that we all did, trying to get testing to vulnerable communities. Really, we were doing care kits, mass delivery, we were doing a little bit of everything. And part of, I think, what we were thinking about is when you think about these pandemics, by the time they've come into the door, it's too late. What we needed to do was be out in the community and really think about protecting people from their doorstep prior to the bedside. And so we tried to take that community health approach. That work led to me then becoming Senior Vice President for Equity and Community Health, a role I enjoyed very, very much. This position presented itself in 2022 and was an opportunity to really kind of broaden the aperture as opposed to being focused. I've done a lot of national work, but being focused in one hospital, really think about national impact, take everything I learned and really bring that forward. And there's a lot of lessons from managing the work that we did at COVID at a system level and really thinking about community health that still, I think, are especially useful now in our current crisis as it relates to health equity and kind of the political turmoil that I've been able to draw from that.
Thank you. Helen, same question for you, kind of reflecting on 5 years ago and your leadership now as the head of this hospital. What lessons do you bring to the role?
I think something that we did very, COVID didn't end by the end of the year. I feel like the society kept moving forward. But here at Elmhurst, I think it didn't really end until 3 years after. And I think once we did that 3-year, I still remember it was like April 23, and we were able to take off masks here in the hospital. And I remember we were like, oh, and we didn't even believe we could take them off because the hospital settings, we still had to wear our masks. And I think once we did that, we paused and said, okay, what are some things we should keep on doing? And what are things we should stop doing? And that was something that we are constantly always looking like, what are some lessons learned from the pandemic? Like certain triggers on patient flow, certain patient flow activities that we've kept. We've also kept this strong connection to the community, and I see Glada here. When Glada came on board, Elmhurst Hospital had maybe like 50, 70 CBOs that they work with. Now we have over 238. That's something that we've made a conscious effort to still stay connected with those CBOs, because they were such partners with us during the pandemic and during the vaccine rollout and testing rollout. Now we're partnering with them, like how do we help with health disparities? How do we make sure we control their hypertension, blood sugar, cholesterol, asthma? So we're continuing that partnership. So I think that was one of the best gifts that the pandemic left us for I want to say leadership and in patient flow.
So I want to stay with you on this question. I mean, we're intentionally call this kind of a abundant leadership, which I think both of you really represent in terms. And the word abundance is one that Epicenter has kind of clung to from our beginnings of saying we will act in abundance. Now, whether we really have it or not is definitely a question, right? But I'm really proud that to this day, if someone needs something, we kind of try to figure it out, right? That's how we apply this. I'll just, brag about you for a minute. And I said this, there's not a time I've asked you for something that you're not trying. So I guess I'm wondering, what fuels that for you? And I'll disclose, sometimes I'll even say, Helen, we have kind of an information campaign we're doing in Queens Village or Brooklyn. We work in Brooklyn. This stuff is not necessarily going to stay in the Elmhurst area, and you'll be like, I don't care, it's going somewhere, just go. So is that
Clara is yes.
Yeah, is that a liberty that you have learned? Is it just the way you're wired? What's the abundance that you're leaning on there?
I think it's a mix of both, and I think you will attest to it. So one thing the pandemic left us, especially for our communities of color, is that we are using our titles and our positions to make sure our communities don't get left back again. Mm. That if the next pandemic comes along, whatever it's financial, governmental, political, or disease-based, our communities have the right tools now to fight whatever is coming. And I think that's my drive because we saw so much despair during wave one that I think as leaders and products of our communities, we want to make sure that that doesn't happen again. And if it does happen, we're just a little bit more prepared. That's why I'm like, let's make it work. If there's an idea that we can try and it works in Brooklyn, it could work in Queens. And if we're doing something in Queens, could it work in the Bronx? Because we're all interconnected. And I think that's where that abundance is. Like, and my team will tell you, I'm always like, well, what if it works for one hospital? It could work for 10. Or a system of 10.
Which certainly in Queens in that period, there were so many family members, for example, you remember this, of people who couldn't get, for example, a vaccine in Colombia or India, and they were coming here. And I feel like that global outlook also informs some of the strategy. Joe, speaking of strategies, you mentioned Spanish in your hospital. You devised this innovative program to communicate with a lot of the patients you were seeing. So I wanted you to reflect on abundance and leadership, but I did think that was this very good specific example of thinking creatively around this.
I'm happy to share. I just want to add too. I mean, I think the pandemic was the worst of times for all the reasons we know. It was the best of times because you saw the best of people, right? And you saw the sense of innovation that we bring forward. You asked like what leadership lessons, right? This idea of thinking ahead, being steady, trying to help anyone. I think the other couple of things that come to mind is, during that time of crisis and being an incident commander, I learned from some people who are really good at emergency preparedness and incident command. You learn these leadership skills around know what's big and know what isn't, like being able to prioritize in the moment. I think those are skills that you really move forward. And the other one is communication. Like, you cannot over communicate. And in the absence of communication, misinformation, miscommunication, and assumptions fill the void. So those are some things that I also think about. The item that you're referring to, the situation, the strategy that you're referring to, is something we created called the Spanish Language Care Group. So Mass General, like many places, it was early on in the pandemic, and I started to get calls from the ICU, my colleagues, and from the ED. Hey Joe, it seems like every third patient we're intubating is Latino. ED, it seems like every second patient is coming here is Latino. And thank God we collected data. And I remember doing walkarounds and seeing this. And very quickly you realize now 40% of our patients, go to 40 to 45% were Spanish speakers. They were the essential workers of all the things that we talked about, impacted by all those things. And when I did walkarounds, we have at MGH very, very strong interpreter services. We did about 150,000 interpreter visits a year, live and virtual. But when I did walkarounds, it became very clear to me that you had people who really cared, trying to do the right thing, but they were innovating in ways that weren't ideal. You had people using their iPhones in a plastic baggie and having a family member on FaceTime to help interpret because we're trying to preserve people, so we couldn't bring in interpreters and virtual and the like. So I struggle with this, and I'm like, man, we need to be able to do better to help people communicate. It's impacting the Latino community disproportionately. A lot of these are Spanish speakers, and so what can I do? What can we do? And so we also had a registry of our doctors and their race, ethnicity, and the language they spoke. And so what I told my team to do is I said, please pull out that registry. I need all native Spanish-speaking doctors. They pulled the list. It was, these are native Spanish speakers, 52 from 15 different Latin American countries in 15 different disciplines. These are from pediatrics to professor of surgery to neurologists. Some of these people were sidelined because of COVID, so that, the pediatrics people weren't, they were, and some people were being redeployed. And so I made a call to them and I said, our community needs us. What I'd like to do is we can be a surge team. So, and we fan out in the hospital so that every day, 24/7, we have a Spanish speaking doctor with every surge team. And so we set this up and we had 7 doctors during the day, 3 doctors at night. We did that for 6 weeks. And basically what we were able to do is with every surge team, I'd walk in as a Spanish speaking doctor and I'd say, hola señora, ¿cómo se siente? And you could just see we're all like masked up and all sorts of stuff. But just that simple ability to have the language spoken, the patient looks up and it's like, it's meaningful. And so some people say, well, you guys were acting as interpreters. No, we brought clinical, cultural, and linguistic competence to those encounters. And it was by far the single most meaningful thing I've ever done. And they were all volunteers, by the way. These are people who could have been sidelined or redeployed elsewhere, who kind of came and stood up for their community. So it's really amazing. And I think it also, maybe I'll end by saying that in this time where diversity is being challenged so much, we had so many of our peers say, I really understand the importance of diversity now. Like, I get it, we used interpreters and like, but what I'm watching with you, meaning all of us interacting with patients, that's the real importance of bringing that kind of diversity and having that cultural linguistic competence at the bedside.
So you said the word, so I'm going to lean into it, diversity. Your own identity, both of you are Latino leaders of mainstream institutions, right? So how does your identity inform your work? And how do you see that kind of in the next 4 or 5 years, like moving forward? It's like, okay, I said it. I set you up.
I'm very proud of my culture. I'm proud to be first generation. I'm very proud that I speak Spanish. I'm very proud that I speak Spanglish. I'm very proud that in my C team, 90% of us are first generation. And I think that comes from my own culture. When I wanted to create my C-suite, I wanted to make sure that we were the most diverse and the most culturally diverse as well, to make sure that we represent the 6,000 people that work here, because they're diverse as well. So I think that's just part of my own DNA. How are we gonna face the next 4 years? I'm gonna say this with cojones. I'm gonna face them hard. I'm gonna face them. I'm not gonna change who I am. I'm not gonna change my mission statement. I'm not gonna change giving the services that we provide here. I'm going to be very proud. I'm going to hang my rainbow flag outside. I'm going to be very proud that we have a Pride Center. I'm going to be very proud that we provide women's reproductive rights here. And I'm going to be very proud that we do everything we can for everyone that walks through our doors. Now, knowing that, I know that comes with a financial risk. But that's why me and my CFO and my finance team, we have to make sacrifices. So I'm like, okay, maybe we won't do that bathroom, or maybe we won't hire X or do that program or fill out that, get that new machine that we wanted to get. And we need to save those pennies, or for us, those millions, because we are staying strong with our own diversity. And, the next 4 years, I'm going to face them hard, and I'm going to walk the talk.
Jump.
I sit in a different perch now in the policy space, and a foundation that really focuses on funding and advance. Our mission is high quality care for everyone, right? That's our goal: affordable, high quality healthcare for everyone. And so we try to really advance areas that focus on coverage. So right now we're really focused on defending Medicaid. We're trying to do a lot of work in care. Clearly, we compare the U.S. to other countries. We spend the most and have the least to show for it by a lot. Lowest life expectancy, highest infant maternal mortality, most chronic disease burden, greatest disparities, despite spending 5x of what other similar countries spend. And there's a lot of differentiators, but one is primary care spend. Those countries spend 15%, we spend 5%. So we're doing a lot of work on primary care, doing a lot of work on cost of care. We have a lot of people who are trying to just, quite frankly, make a profit on healthcare and putting profit over patients, and that's an area that I think is of great interest to us. These all have connections to equity, because at the end of the day, all these things, not only do they directly impact people of color, but fundamentally vulnerable populations always suffer the most in any of these areas. And so we're digging deep in that. Our single biggest portfolio is equity. It's part of our DNA. It's part of who we are. And strategically, we are not going to abandon our values, and we are digging deep on that work. Now, you also need to be aware, like you said, how are you kind of going to manage a situation where, they're searching words or doing this and doing that. I think retreat or overcorrection is not what anybody wants to do, especially given our identities where we're fighters, right? That's who we are. That's what we do. and that's the way we're wired. And so part of it is walking the tightrope between staying strong and being clear and reassuring the team that we're doing that work, and trying to dodge getting in the crosshairs of distraction. Because fundamentally what can happen is that, you end up with a lawsuit, and even if it's completely frivolous, it takes my time, it takes our money, and it takes our team's time, and it creates a lot of anxiety. What does that do? Take us away from our equity work. We can end up on Fox News because we funded something. What does that do? Creates churn. So what I'm trying to do is thread the needle to say the single most important thing we need to do is the work, and the single worst thing we do is take unnecessary risk. Not overcorrect, but just be sloppy right now. And so being strategic in this moment, I think, is really critical. And having done a lot of work in a lot of places in health equity in red states where it had been challenging, I learned a lot about how to do that. And so this is chapters being written right now. I'll end by saying that part of what we faced is a complete and effective, very, very effective co-opting of the words diversity, equity, and inclusion. The messaging is very simple. It's a straight line. Diversity is incompetence, equity is advantaging people of color at the expense of white people, and inclusion is political correctness, right? They've been able to make that connection very clearly. It is on us to be very clear and precise about what we need, and not be fighting the words the way they define them or be on our back foot. No, it's not incompetence, but to say this is what we need. In a healthcare setting, we need people who represent the community, who can communicate, who increase quality, improve experience, increase access. We need equity. Yes, we want to make sure that no matter who enters Elmhurst stores, they get the best we have to offer. That's equity. And inclusion, we want a workforce that feels valued and respected with the pride flag outside. So that clarity and precision is really, really important now. And that messaging and not being afraid to, sometimes we get a little too academic about how we're explaining things, just keeping it real simple. This is what it is. And reclaiming that narrative is going to be critical in the months to come.
I'm going to turn it over to you for your questions in a moment, so just start formulating them. I will ask if you identify yourself, if you have like a quick, where were you 5 years ago, or a COVID recollection, but quick. If it goes on, I'll cut you off. And then what your question is. I'll turn it to you in a moment. I do want to get to community hospitals and what role they're playing now. I mean, I do think 5 years ago, kind of to your point about why that line was so long and the critical role they play in the community. I'll tell you, we did a lot of work in Queens Village, for example, which is one of the least vaccinated areas of New York City. People there have still not forgiven the hospital closures of 15, 20 years ago, right? Meaning we're trying to deal with a crisis right now, but people, of course, won't forgive you if you were there and suddenly aren't, right? And that was just a kind of wake-up call for me. I just wonder, how you're situating community hospital work.
There's a lot, kind of like what I was saying, there's a lot we have to heal, but information is key. People have certain populations have gotten stuck to a word or a situation, and we just have to just give them an explanation, give them the information to help them redefine it. It wasn't our fault that some hospitals, that St. John's closed. But I'm like, okay, what was St. John's giving you that we can give you? Because you might not know we're giving it. Or how do we help you advocate to your city council and your state assembly and your senators on how to get a hospital back? Or how to get the services that you need or get community health centers. I think for us here at Elmhurst, we really have been committed not only just being in-house, but also making sure we have our connections strong with our communities, like partnering up with you now, but like Joe's my new best friend now. But also like making sure like we partner with voices, we partner with all the churches, we partner with all our elected officials. We make sure that we're trying to hear all the voices and figure out like what are the needs that we need, not only as a community, but what's our role in that need. I wish I could build housing. I wish I could build 30 buildings right now and put everyone who's homeless or who's has home insecurities into the right place, in the right setting, right? Because when you don't have shelter or the correct shelter, you won't get healthy. There's no way for you to heal on the right healing path. But I can't build. So what do? I partnered up with Jocelyn Canal and even the housing services. Believe it or not, I'm partnering up with the banks to be like, hey, can you educate my community on how they can get a mortgage? Because many of our community members don't know how to get a mortgage. They don't like, okay, we can't afford a house yet, but what about a condo? And what's the difference between a condo and a co-op? I think that's huge for our community. Now, where health comes in place, that is like, if your primal need of having a home and feeling safe is what you need so you can take your hypertension medication, then let me figure out how to work on that. I think that's a big change that we've had.
Joe, before we turn it over to the audience, I bet you're about to hear versions of this question, but I'm just going to come out and ask, what are your funding priorities right now? If somebody in the audience wants to be funded, what should they do? I think that sort of kicks us off, and then we'll turn it over to the audience.
So as I mentioned, we're a national foundation and we do policy, so we don't do kind of direct local support. That being said, we're about to launch an effort that does focus more on New York City, and so stay tuned there. The idea that we're kicking around is we've had programs. The Commonwealth Fund has had programs in New York in the past, and I think it's important that we, being in New York, make contributions to community-based organizations and partnerships that allow us to do two things. Number one, support them, but number two, give us a chance to learn with them. When you're doing national policy work, and we're talking about all these things right now, I mentioned we're doing work in coverage and care and cost. We have some international work, health equity, all important. But I don't want our team sitting on, Manhattan trying to work on policies and not have the lived experience that we can access here in New York very easily. I also don't want to be knocking on your door saying, hey, can I bring in people at 20 and you can host us for all day? No, I need to create situations that are mutually beneficial so that, because I've been on the other side of site visits and all that stuff. It takes a lot of time. At the end of the day, you're like, well, that was nice, but we're busy here. Like, we want to build those relationships. So more coming in that direction that I think will have direct relevance for what we do in New York.
Thank you. So as I turn it over to you, I'm struck a group of nonprofit leaders are here from, I think, the March of Dimes, Queens Together, Bronx Defenders, maybe, if I'm getting them right. And they said, as we walked in, we just want you to know, especially this week, we felt really safe coming here. So I just thought that was pretty remarkable. I also share that because, this idea of safe spaces is also under attack, but I do feel like we are in a safe, welcoming space, if you can't tell from Helen's demeanor here. So I'm turning it over to you. What are your questions? Should I give them my mic, you guys? Do you want to?
Just repeat the question.
Just repeat the
I'll
question.
pick it up.
Okay.
So Carolina, let's say I work at Epicenter, but I was in the neighboring district with Councilmember Moya, and the linguistic and the cultural competency were like front and center. And it was very frustrating because the resources that we needed was to be able to speak to people and in the language that they understand. So I'm grateful for people that understand that. So my question is, how can us neighbors and the community support the work that you're doing? What would be helpful for us to do, whether that's speaking up or that's telling people about something? How can we help you guys do your job?
I think it goes back to what Joe mentioned earlier, fight the misinformation. There was, very annoyingly, a thing on Instagram on the hospital that we were we were giving IDs to ICE or something like that, and if you know Elmhurst or you know me or anyone from our team, like that would be like impossible, so if you see that, say, write a comment or whatever, like, I either work at Elmhurst, my family members get thing at Elmhurst, that's not something aligned to their mission. I think that, because if there's like about 30 people here, if 30 people post, let's say you saw this, and you post 30 times, hey, this is not true, the false information will die down. Because by the time I got to hear it, it had like blown up. Like it was already at the state by the time I got the phone call. And I think, but how many more people saw that and didn't come in for healthcare?
So I just want to give you what was happening around that. We saw that on Instagram, and like some of you were on a neighborhood WhatsApp chat that's quite, or a neighborhood text chat that's quite active. And someone put that out and I said, it's impossible. I know Elmhurst Hospital. Thankfully, one of the people in that chat is a reporter at WNYC, and the CEO of WNYC, LaFontaine Oliver, is here today. And then WNYC did a story saying, this is not true. right? I think they did it the next morning, but they did the story. So I do think that's a good example of kind of the community vouching for the institution and then putting it in a bigger pulpit to correct the narrative.
And then because we are healthcare providers, go get a physical. Like get your vaccines, get your shots, stay healthy, or just find out what what's your blood work, what's your regular, what's your cholesterol, like find out what's going on with your body. Because the only way I want all of you here for the next 100 years, but you're only gonna get there if you have good health. And the way to start is seeing a primary care doctor. So please start there as well.
Jill, question on the linguistics. Any thoughts on that? And certainly in New York, it sounds like in Boston, this is something that you've worked on. And any thoughts on the question there?
Yeah, I mean, there's been so much evidence on the impact of language barriers on health and healthcare and trust and experience and satisfaction and follow up. We were doing that work for years, and I think the good news is we've seen an evolution. I think technology is helping us, just to be honest. I think at first we were a little skeptical about technology. We said, no, we need a live trained professional interpreter. But I've seen some things now technologically that are evolving that are pretty amazing. And I think it's going to give us a chance to really be next level. I mean, one of the things we were piloting at MGH was literally you and I wear a headpiece, a little earpiece, tiny little thing, and you speak and I in Spanish and I hear you in English. And it was, kind of live interpretation. It was unbelievable. And, the ability for me to look you in the eye and you to speak and for me to understand your language and me to speak back. And we tested it out. And so we were piloting a lot of those different things. And so I think that's going to be a big, and I think it'll actually improve care because oftentimes I'm a staunch interpreter, a staunch advocate for interpreters, but it is a third person and, you lose something in that transaction. And so I do think technology is going to give us a big leg up, and I think these things are going to be easier and better. They're going to come in scale, and especially here in Elmhurst, I can't even imagine how many languages you all have here. I mean, yeah, there you go. You know exactly, 138. Right. Things like this is a game changer, and the spend and the impact on quality and patient safety and patient experience, all those things that have value is really.
Yeah, we've been using AI and videos to exactly correct the narrative in Spanish on Instagram, like just kind of enter the platforms where people are. There's a question back there. Go ahead.
You feel you like wanted something. That's a loose say who you are.
Oh. I'm Dr. Liu. I'm the one of the hospitalists. 5 years ago. We treated some COVID patients, still emotionally very traumatic. So I want to say something. Okay, first, you mentioned this community hospital, but that means we are serving this community. But this hospital is a big teaching hospital. We have so many level 3 trauma. We have very advanced cardiology department, very advanced neurosurgery. So actually it's major teaching hospital. It's not just a little community hospital. Okay?
So sorry. Nobody really have a shot.
Okay. So let me repeat. I'm a hospitalist. I'm Dr. Liu. I'm from China. So when first, before there was SARS, my first name is Guangdong. So no one paid attention to my first name, but one day everyone called me Guangdong. You always call me Dr. Liu, no one called me Guangdong because SARS came from Guangdong. So, I feel the pressure, So that's why, yeah, I want to mention this. And also, I want to thank the leadership, during the pandemic. Treating pandemic is like a big battle. So all you need, first you need all the supplies. Before your fight, you need all your supplies to be ready to be delivered. And during the whole pandemic period, we have enough oxygen. Then I learned that oxygen actually from LaGuardia Airport because all the airplanes up, So we got aviation oxygen. That's why we saw all the oxygen tank like a missile. This So, and we got all the oxygen, we got all the food, we got all the medicine. So, and also we got all the PPEs. And also for example, for the ventilators, we got 17 all kinds of ventilator like regulations. It's we don't know how the leadership got all the supplies for us. And also, it was amazing. The whole ED, I counted, there were 253 patients living in ED in April. How they got all the stretchers. When you want to see a patient, you have to really squeeze in, like, they're all parked like valet parking, Right. So it's, we got all the supplies, and also we got food for the employee, for the patient. So the supplies, it was very, very important. The other part is managing all the employees. We have volunteers from the Navy, from Army, from California, from all the place. But the leadership handled all this really well. This is the major part. And also, whenever we say, the community only see physicians and nurses. But actually, the bigger part is the people in the faculty. The people clean the room, people provide the food, people handle the bodies. They're all very, very important. But the community only say, thank you, doctors, thank you, nurses. Yeah. But that part is also very important. So, can I say, definitely, Dr. David. Okay.
Dr. Liu is very humble. He was very important not only during the pandemic, even just yesterday, he was helping us with a small surge. But it's compassion, like the provider, that you are, Doc. It's the compassion to teach, because we are teaching hospital. The compassion that he teaches not only the patients, but the residents, the fellows, and the med students, and even other fellow young attendings. He's a huge mentor, and the stuff that he did during the pandemic was not only innovative, but it was full of compassion always. So
I just wanted to pick up on that because he talked about the teaching aspect of this hospital before he had the mic, which is so important. This hospital also taught me one of my biggest lessons in 2024 from a resident. My mother was rushed here on July 4th of last summer. And if you know the busiest day in the emergency room, it's July 4th. So my mom has a heart attack. There's fireworks people who've done all sorts of bad things, right? Some of them are under arrest and some of them are victims of whatever fireworks were going off. And I said, wow, Elmhurst Hospital really is centering equity, as doctor just pointed out, as Joe just pointed out. And the resident says to me, if I could correct you on one thing, at Elmhurst Hospital, it's not just that we treat everyone equally, we treat everyone like they're important. And I just had a very emotional reaction to that because I thought about the difference between equality and kind of centering life as important, right? Someone who's under arrest, my mother, and the person who was the victim of whatever firecrackers were going off that night. So yes, it's a teaching hospital for all of us. Other questions? Back here.
You'll take the mic. We'll share this one. Okay.
My name is Robert Snyder. I edited an oral history of the pandemic in New York City called When the City Stopped. And in a lot of the interviews that I looked at, healthcare professionals reinvented their jobs in the worst days of the pandemic. They came up with new procedures, reached out to colleagues in other hospitals, asked them how they met certain difficulties. I'm wondering if you have examples of that, and have you been able to institutionalize some of those practices that were reinvented on the fly to provide better care in emergencies in the future?
So for here at Elmhurst, I'm very proud there's a lot of stuff that was done here at Elmhurst that we were the first. And not only was it spread throughout the nation, but even globally. I think one perfect example of that is how we delivered babies during the pandemic. Because remember, babies were still being born. You know, there was a lot of stuff going everywhere. And how do you deliver a baby whose a mom is COVID positive, but the child is not yet, you know? And, you know, the innovation that happened to ensure the safety of the mom, the baby, the staff. I mean, we went from like plastic walls to no walls to like things sucking out air, things putting in air. I mean, the procedures that we did to make sure that we continue having healthy babies during the pandemic was huge. I mean, even how we would deliver the babies, deliver the mom, and if the baby and the mom were okay, we would discharge them like within 24 hours, which is unheard of. And making sure we do the follow up care, like certain stuff like that, just making sure the next generation of life was being saved and making sure they were safe. The stuff that we did that was practiced throughout the nation. And of course, anything with like, you know, and I have to give Dr. Stewart a shout out. I mean, the stuff that Dr. Stewart did in the ICU was beyond innovative. Like the amount of lives that man saved on innovation alone. And then I also have to thank, you know, our late Dr. Massey and Dr. Polakar, the stuff they did with infusion when you got COVID, you know, our infusion center. I mean, that was also mind blowing, the stuff that they did. And then again, all the clinical trials that happened here. I really want to thank the community for being open minded to let us try different things that save not only lives here within our communities, but save lives throughout the nation.
Yeah, let me say something, you know, very simple, just in a few days, we have a divider to divide oxygen, just one oxygen,
Right.
we can have 10, like 10 connectors, so 10 patients can sit around that huge tank, getting oxygen like home.
That's thank you to the facilities. Diana's here.
As Stuart did a turning patient, you know, upside down, also with a long.
Oh my God, that's I forgot about that.
Yeah, that's what I was going to say. I mean, so I have a couple of clinical. First, thank you for your question. And you know what I said was the best of times and the worst of times? That was the best of times. I mean, when we were in the pandemic, I remember laughing because, you know, we'd work till 10 o'clock at night. So if you and I needed to solve a problem in today's day, we'd say, oh, you know, we'll set up a call in 2 weeks. It was like, I'll call you at 9 tonight. And we'd work. And I remember we'd laugh and say, God, can you imagine in normal times? Like we'd say, yeah, you know, set up a meeting. I mean, it was like on, and it was so high adrenaline, and it was so it was so hard, it was so gratifying because you knew like every minute that you could waste a minute because it was a life. So a couple of examples, clinical and non-clinical. I think the clinical ones, proning. I just had a patient in the ICU of mine the other day. They were using the same proning that they did during COVID. The proning that happened in the ICU is evergreen now. I'd say another key thing that we did was mobile. Like many places, we launched mobile. We first launched mobile to do community messaging, to just tell people vaccine was coming, answer questions, do testing. Then we did mobile to test and treat. We still, when I left Mass General, we have now mobile that's doing diabetes screening, a bunch of other things. We've always had mobile. This is like a lot more directed and connected. Like the idea of going to where people are and where communities are, I think that's stayed. This idea of information, we launched in that Spanish language care group. There was about 20 doctors who would do any media in Spanish, right? We've kept that alive. So we have a team now. If the media has any questions related to anything healthcare, they ping us. There's a whole group called Conectar that now will fill that information gap. That came from the pandemic. And you know, you had things like the barriers where you put your hands through and do testing and the plexiglass barriers. It was an amazing time. And I'll just say that what I lament is that we don't bring that same energy to crisis like substance use disorder or mental health. Like I think we need to stop everything, you know, like we did during COVID. You manage these things, but I think the crisis of mental health and substance use now requires that same level of like, let's all go. Let's go. Let's like line up. Let's work hard. That's what I regret because I think that was such a special time. And it's not just COVID. That's not the only pandemic we're facing.
Other questions?
Jackie.
Sure.
Hi, I'm Rebecca Newworth. I work with Documented, big, huge fan of Deidre's and the whole team at Epicenter. two quick questions. One is that 5 years ago, I was just starting in a nonprofit called Upwardly Global that worked with immigrants who came to the country with professional backgrounds, and we're trying to get reconnected in their fields. And one of the big ironies was that there were so many people who had medical backgrounds, immigrants who came here, nurses, doctors, specialists. It was unbelievable. People who had worked in the Ebola crisis, I remember, and who had no opportunity to actually do anything in hospitals at all. You guys have been speaking about such abundant leadership, so much ability to think creatively, to really get stuff done. I remember at that point there was quite a bit of progress made in terms of trying to figure out how can we plug in immigrants, how can we figure out different ways of certification and allow people to use their skills in hospitals. I was just curious if that's going on at all. And then the hook-on question is so much positive energy and memories and so much unbelievable work that's represented here. But something changed, clearly. There's just this immense lack of trust that shifted from all this amazing energy and time, and we're in that space right now. Just curious if you would all, actually, including you, need to reflect on what happened recently.
I'll just take the first one real quick and turn it over. I mean, if you Google Massachusetts just passed a bill exactly on that, is how to fast track health professionals with international degrees to exactly address that need. That just passed probably within the last 3 to 6 months. So I would Google that, and that's a great model because of exactly what we learned with COVID. You had all this talent, and we have a primary care crisis, and there's a workforce shortage. So take a look at that. There's probably other models. I think California had one too, but that's a very concrete example of ways to fast track that. Yeah.
I think you're right. I think California has it too.
Yeah.
I'm trying to think. What was your second question?
Trust.
It was trust. I do have to tell you, for here at Elmhurst, we feel the trust with the current political climate change. There's a lot of health centers and other hospitals that are seeing a decline in their amount of visits. Not here. We are very full. I can tell you because the ED was very packed 2 minutes ago. And I think it's because they trust us. Whether there was this misinformation on ICE being here at Elmhurst, it didn't stop them from coming. So I think Elmhurst has stayed strong in the idea of trust within our communities. And again, because we've been very focused in making sure that we stay with our community partners. The pandemic has passed us, but there are other pandemics. Mental health and substance abuse is definitely the next wave for us. And we've stayed strong with those community groups. So I think for us, the trust has stayed there. If anything, I think we made it stronger.
Could I just one more thing about trust? I'd say, trust is earned, and there's plenty of reasons why people are mistrustful. We said that going into the pandemic. Everybody said, "Well, people of color are not going to get vaccinated because Tuskegee and there's a long list, right?" And at the end of the day, I'll give you an example of Chelsea. Chelsea was in Massachusetts, one of the hardest hit places, and then ended up being one of the highest vaccinated. All people of color, women, Latino. Part of it's because a lot of them had been hit by the pandemic, and they wanted any solution. But part of it's because we were on the ground trying to earn people's trust. And where we felt short in the pandemic, and I think something that's a key ingredient to building trust is humility. And I don't think it was intentional, but fundamentally, I think what happened was a series of communications that were leveraged as this is the forever truth, when it is just the truth that we know in this moment, and it might change tomorrow. So when we told people, yeah, if you get the vaccine, you're not going to get COVID, and then they got COVID, they're like, what happened? Well, no, if you get the vaccine, you're less likely to end up in the hospital or die. Yeah, but you told me I wasn't going to get COVID. You lost some trust. And when you tell people, well, you're not going to need another vaccine, So I think the key lesson here in earning trust is being humble and saying, look, I care about you. And I'm just doing the best I can in this moment. This is all I know. And all I can tell you is it could change tomorrow. But I'm trying to do the best I can. Like, bringing humility to the conversation, I think at least gives somebody to say, okay, I can trust that they care. It's nothing else. And I can trust that they're being honest. So I would just add that.
I'll just quickly echo the trust is earned. So our experience has been, if you came to us for a COVID vaccine and we helped you, whether it was through information or literally booking the appointment, then you probably called us again, but it might not have been for something health related. right? It might be my child just arrived in America and I need a tutor, right? And if we help you or we're feeling committed, right, from that abundance mindset, you'll probably call us again, right? And so from an information needs of what Epicenter plays in the community, you know, COVID was treated as a health crisis, which it was, but it was so many more things. And so I think there is a correlation between 5 years ago and your question about the lack of trust now, was a question of whether institutions kind of looked at the whole person in that way. Now we have a luxury in media, I think, of being able to do it, although I question how much of mainstream media approaches their readers or viewers or audiences or communities in the same way. And then the other piece is economic, which I don't think it's a coincidence that the three of us in some capacity, whether we're talking about mortgages or helping small businesses or, have really seen wealth creation as an important part of our role in the community. And I do think there's a question mark over calling people essential and suddenly they're dispensable or deportable or whatever we're seeing right now. And so I think that trust was clearly fragile or maybe never earned to begin with. And the last thing I'll say, I think I can go out on a limb and say all three of us probably serve a heck of a lot of both and all sides of America, right? I mean, I feel like from a needs in Queens, like we're with all parts of the spectrum, and that's not really how I'm assessing your needs or labeling you as a user. It's really on the question of what do you need and not how did you vote. And I think we need to think about that a little bit. Other questions? I think Mia had one, and I'm just going to give her a shout out because she's our artist in residence at a store not too far from here, Art Retail Therapy. So if you get a chance to check out her work, go ahead.
Hi everyone, I'm Mia Blue. Yes, as Mitra was saying, I am artist in residence with Epicenter. And so I'm bringing this artistic activist viewpoint today. And I just wanted to talk about some holistic health efforts with Elmhurst Hospital, and specifically the New York City Health and Hospitals Initiative with Artist in Residence program, which, if you're not familiar, Carla Torres is the artist in residence at Elmhurst Hospital. And so thinking about holistic health and addressing Elmhurst Hospital's community and a holistic set, addressing the mental health pandemic that we're still seeing, and also just addressing the current crisis with political events, and addressing how we can all cope with that and care for ourselves. So I'm curious what Elmhurst Hospital is doing with Carla Torres, and also just in general with creativity in their community.
Well, first, I love arts and medicine. I think it's a system-wide initiative that we have where we really bring the arts into our hospital, whether it's a painting, in one of our walls, or it's music playing in our lobby, like classical music, or dance, or any type of art, and even us doing art ourselves, building murals with Carla. I think the arts and medicine and having Carla here, it really gives us a new sense of how to express what the other side of our brain needs. And I think when we relax the right side of our brain, and then we're coloring either by numbers, because I need numbers, because I can draw anything, or really brainstorming, like, what does the work that we need to do, what does that mean into colors? I think that gives us a moment to pause. It builds teamwork. And in that pause and building teamwork, all of a sudden that problem that you had in your head on how to take care of patient X or patient Y or that unit, or how to talk to that provider, or how to talk to that nurse for this patient or advocate for them, it solves itself. So art has been a way to unite not only the staff, patients, and I feel like it trickles down, right? So if my doctor, my nurse, or even the housekeeper feels inspired because they heard this classical music and they're humming it, and them humming it, the patient hears it and like, oh, what are you humming? It creates a connection. And now that patient sees their experience at Elmhurst a little bit more holistic, and hopefully when he or she goes back to their health journey, they'll hum the same song, and it reminds them of a healing moment, and we break the cycle of being triggered for something bad to something good. That's why I always tell individuals, I was like, when you come to Elmhurst, we're not just getting you better, you're on your health journey. And I think arts and medicine helps us to understand how we use arts to make sure that journey begins.
Great, Jimmy.
I think that's a good note to conclude.
It's a good note to conclude on. Also at Epicenter, you might know we weave art into everything we do. So please do check out Mia's work. We also weave a lot of food as a sign of our abundance. And so on the tables back there, there's still a lot of food. Each of the vendors are folks who we worked with 5 years ago. We continue to work with. They're restaurants that we've profiled. Some of them turn to us for help navigating their own PPP loans and paperwork and getting access to information during a critical time in their business. And we're really grateful they keep hanging with us. And I always say it wasn't charitable for me, it was personal to keep them open because I am a resident of this neighborhood and love their food. I can't thank you both enough. This was really restorative for me at a moment that just personally I really needed this. It's kind of, you gave us a guidebook for how you approached 5 years ago, but I feel really inspired for the road ahead.